Thank you so much. And thanks to Vikas and Prabhat for organizing this meeting, which is the crux of oncology, is actually supportive care. And I'm glad to be talking about a rapidly emerging problem, which is the growth problems which occur in childhood cancer survivors. Um, Growth, just the physical growth, is just not about the physicality of the or the body proportions. It has a huge impact on the overall well-being of the child. So having an abnormal physical growth affects not only the motor development but also significantly affects the cognitive development as well as emotional development of the child. And hence it has become important for us to focus on growth problems very early in the childhood cancer journey. So we, as you all know, there are various growth nomograms which tell us how much a baby who is born gains in the first few months to the first few years of life. And these nomograms have been developed on normal population and are varied from different type of races as well. So we know how much weight gain would occur in the first few months to the first few years. What would be the growth in head circumference? What is the growth in length, etc. And these are all well mapped out, and the nomograms available for different population. Similarly, we also know the height velocity. So we know that the height, the proportion of centimeters per year, what increases in the first few years of life is much more than what occurs in the 5 to 10 years of life. And then there is a growth spurt which occurs during the puberty, earlier with the females and so later, bit later in the males. But it is important for us to know that while doing treatment for childhood cancer, that the growth is what is getting significantly affected, and that needs to be kept in mind. So you all know that childhood cancer has achieved high success rates, especially in the high-income countries, and even in a country like India, where although the average survival may be only about 37-38%, in centers, tertiary care centers where multidisciplinary treatment is being provided, especially with multimodality therapy, outcomes are well over 70%. And in a place like ours, Tata Memorial Hospital, our overall survival is well over 75% at 5 years of age, which means there are more and more childhood cancer survivors whom we are seeing in the present day. And in our own late effects clinic, we have now more than 4,000 long-term childhood cancer survivors. So who do we call as a childhood cancer survivor? So someone who has actually completed 5 years post-treatment and has not had a relapse and is free from disease is whom we would technically call as a childhood cancer survivors. So with the number of survivors increasing, it was only about 300,000 in 2010 in the United States, and now it's close to 500,000 childhood cancer survivors, means there are adults, 500,000 of them who are childhood cancer survivors. It became evident that they were actually facing late effects of therapy, which we did 15, 20 years ago. So if you look at the blue line, that shows the grade 3 to 5 late effects, the severity of late effects. And grade 1 to 5, the red line, shows the total number of late effects we see in childhood cancer survivors. If you see about 20 to 25 years after completion of therapy, about 60 to 80% of them would get one or more chronic health conditions, which means it was not enough for us to just cure those children of cancer. It was very important for us to very early take into account that we are actually curing the cancer, but we are compromising their quality of life in a significant way, a lot of it due to the late effects of therapy. So we'll now come to the main growth issues. There are many aspects or late effects which will not be covered in this lecture. The main growth issues what we see are short stature, alteration in body mass index, both obesity and undernutrition. We are seeing rapidly an emergence of metabolic syndrome and altered bone metabolism, so bone mineral loss as well as osteoporosis. Now, there are many reasons why impaired height occurs. So the commonest one is intensive combination chemotherapy. So during the course of, say, for example, an ALL treatment, in the first year of life, the growth velocity actually drops. So there's a significant drop in the growth rate, the height. And then subsequently, as the child actually finishes treatment, growth starts to catch up. The majority of the children actually catch up the growth in 5 to 6 years. But if you look at the whole population of childhood cancer survivors and compare them with the normal population in the same area, you will find that about 10% of them they have a significant growth affected, height affected. So a lot of the chemotherapy does affect the epiphyseal growth plates, and chronic myelosuppression during maintenance as well as steroids, which causes early epiphyseal closure, affects the ultimate height the child gains. In addition, RT is one of the common modality we use, especially in brain tumors. And then radiation to the spine occurs to the long bones in many of the sarcomas, and that also significantly affects the height and causes height reduction. Along with just the epiphysis getting irradiated and height being affected. Cranial irradiation also causes growth hormone deficiency, central precocious puberty, hypothyroidism, all this which have an impact on the height. There are other causes for impaired height as well. Bone marrow transplant, where you do TBI, causes growth hormone deficiency as well as direct effects of radiotherapy on the bones. Many tumors cause growth defects, hypothalamic tumors, craniopharyngiomas, pituitary tumors, etc. Chronic or severe infections, undernutrition, many of the background population come with. Along with that, they go through cancer therapies. They have poor oral intake, cancer cachexia, anemia, and organ toxicities. All this play a role in affecting the height of the child. So this is just to show the data that actually, if compared to chemotherapy and cranial radiation, chemotherapy has much lesser effect on the height of the child compared to the radiation, cranial radiation. And the lower line shows the effect on the height by when you use cranial RT, and the top line actually shows chemotherapy only. And this is the average of both of them, shows that there's significant drop in the ultimate height in childhood cancer survivors. So very closely related to height being affected due to the bone is also growth hormone deficiency. It is the earliest hormonal deficiency which we see with cranial radiation, and we see it in almost 1/3 of our children with brain tumors whom we treat. And the risk increases with radiation dose. And it is sensitive to growth hormone, is very sensitive to low doses of radiation as well. So the commonest number of cohort we have in our late effects clinic with growth hormone deficiency are brain tumors and ALL who received previous cranial RT on the MCP 841, which now has completely stopped. And so that we should expect to see much less of a problem in the subsequent survivors. So this graph shows that it is dose dependent, the amount of growth hormone which is affected. If you give the hypothalamic dose of 10 gray, not much effect, but once you reach 30 gray and above to the hypothalamic pituitary region, then the growth hormone secretion significantly drops, necessitating that the children would actually need supplements. Now, there is a question of when do you actually start growth hormone treatment? I mean, it is an expensive therapy to do. When would you start the replacement? So there was a lot of apprehension that if you give growth hormone early after completion of treatment, that the cancer would recur or it would actually cause the cancer cells to grow as well. But over a period of time, many papers have come out, which shows that it is more an apprehension and not heavily scientifically based. And so more and more groups, cooperative groups, are now started to give growth hormone much earlier. So previously, we waited up to 2 years after completion of treatment to start growth hormone, but now we have brought it down to 12 months, even at our hospital as well. The reason we had to give it early is it's most effective when started early before the epiphysis actually closes. So before skeletal maturity is complete, otherwise you will not have any significant effect on the height of the child, though you would have an effect on the metabolic aspect of the child. So for that reason, we are giving it early. We have to needs to be under an endocrinologist. And as of now, at least we have about 40 or 45 children who are on growth hormone at this present time at Tata Memorial Hospital. The other aspect of growth which gets affected is the weight. So the BMI, the body mass index. The initial reports of the childhood cancer study, a cancer survivor study, showed that obesity was mainly noted in ALL survivors. But it also became obvious that it was not just simple obesity. They actually increase in body fat mass and visceral adiposity, but actually the muscle mass came down. So this is what is called sarcopenic obesity, and this is what we started seeing. In this situation, both BMI can be normal, but you still could have obesity. And this is a problem which we have seen in many of the ALL survivors. And if you look at this data, which is a meta-analysis, about 40% of the children, childhood cancer survivors post-treatment, want to become either overweight or obese. The risk factors for obesity, many of them are non-modifiable, which may be disease-related, cranial irradiation, brain tumors, transplant, etc., including growth hormone deficiency or exposure to steroids. And if you look at how it affects, so females get affected more than males, and the dose of radiation, cranial radiation, actually has an impact. If you give chemotherapy and cranial radiation of 10 to 19 gray, then the effect, though it does cause obesity and a rapid increase in body mass index, it is much less than what you would see if you give cranial RT of more than 20 gray. Similarly, the same thing, the females would get affected more than males. And if you then looked at the age, the younger the age group with cranial RT and chemotherapy, the higher the chance of female child becoming obese and having a high BMI. So there are modifiable risk factors for obesity, lifestyle factors, maladaptive eating habits, reduced physical activity which occurs during treatment, reduced energy expenditure, and many times long-term steroid use, which causes weight gain. So we looked at what was the impact of dietary modification, and there were multiple studies which were published on where dietary modification was introduced to prevent obesity. But what became clear that compliance was very, very poor in survivors. So less than half of the survivor population was meeting the recommended guidelines for fruit, vegetables, etc., or going on to a healthy diet. There was very low intake of vitamin D and calcium, especially in survivors of ALL, and female adolescents and young adults and survivors of CNS tumors were at a much, much higher risk of developing obesity than the other tumors what we saw. So there were also predictors, and it was also became clear that they were leading an inactive lifestyle. Some of it due to the treatment, some of it due to psychosocial issues, some of it due to overprotection, which occurred in especially in a country like India. That when we compared the activity which was being done, childhood cancer survivors were less active than a sibling comparison group or an age and sex population sample. And the energy expenditure was also much lower than what was estimated. So it is a complex interplay between the treatment, the psychosocial aspects, and the reduced physical activity which occurred in childhood cancer survivors. So in the last two slides, I would like to just mention about bone metabolism, which is also a significant problem seen commonly in childhood cancer survivors, especially those who have growth hormone deficiency and undergone bone marrow transplant. And that requires addressing on its own. And the metabolic syndrome is now becoming the biggest problem, where we see about 40% of our survivors want to develop metabolic syndrome of some grade. And this has multiple risk factors. One is the treatment related or disease related, and also genetic, familial, and other intrinsic factors in the child, which are causing the problem as well. So managing obesity and metabolic syndrome, there are several modifiable risk factors, and survivors are actually the good candidates for targeted screening and lifestyle counseling regarding risk reduction measures. So there is many guidelines which are available for this nutrition and physical activity guidelines. Various groups have brought out. We ourselves brought out a guideline on how to follow up childhood cancer survivors, including looking for growth, development, and various other side effects, including obesity management. And the time to intervene is what is most critical. I think we should intervene right when the treatment of childhood cancer is going on. Early identification of the child who are with risk factors, especially when they're on maintenance therapy of ALL, in if it's an ALL child, maybe the best time to intervene. We need to keep a close watch on weight, regular monitoring, and recognizing the weight gain, which is crossing centile chart. So it's very important to chart their height and weight during the treatment as well as post-treatment. And they require a comprehensive follow-up with a multidisciplinary team, which will include nutritionists, psychologists, endocrinologists, oncologists, etc. And that's how we will need to work on to actually decrease this rapidly emerging problem. So I think I just give a brief overview on growth aspects in childhood cancer survivors. And I would like to stop here and we'll take questions anytime.